He wakes up in a hospital room that smells faintly of disinfectant and warm plastic. The light is dimmed. Morning rounds have already passed. A nurse has written the time on a whiteboard. He slept, he thinks, or something close enough to sleep that he does not question it. His body feels tired in a familiar way, like jet lag or a bad week. This is not alarming. He is here for observation. That is what he was told. A few restless nights, elevated heart rate, nothing dramatic. He is still himself. The first nights had been inconvenient rather than frightening. Difficulty falling asleep, waking earlier than usual, lying awake while the house settled into silence. He blamed caffeine, then stress, then age. His primary care physician suggested sleep hygiene, fewer screens, regular hours. It sounded reasonable, the kind of advice given every day to people whose bodies are intact. Even when sleep stopped arriving entirely, the language remained reassuring. Insomnia, transient, situational. The word carried familiarity. Millions of people lived with it. It was uncomfortable, not dangerous. He was told the body would eventually correct itself. Exhaustion would force rest. The brain, after all, needs sleep. What was missed in those early weeks was that his body was not compensating. It was not rebounding. It was not collapsing into rest after prolonged wakefulness. His eyes burned. His thoughts slowed. But the switch that normally pulls consciousness down into sleep never flipped. Night after night passed without dissent. This is not stress. This is not anxiety. This is not burnout. This is not the insomnia of modern life. This condition does not respond to reassurance. It does not arise from behavior. It does not resolve with rest. It is rare. It is specific. And once it begins, it follows a fixed biological trajectory. The first sign that this was not ordinary appeared quietly. His heart rate remained elevated even at rest. His blood pressure drifted upward. He began to sweat at night despite the cool room. His pupils reacted sluggishly to light. These were not symptoms he could feel clearly. They were observed. Sleep studies showed something subtle and unsettling. He entered bed. Electrodes traced brain activity. Hours passed. The recordings showed wakefulness. Not agitation, not fragmented sleep. Wakefulness. The architecture of sleep was absent. No slow-wave descent. No REM cycling. The brain never crossed the threshold. Sedatives were administered. Hypnotics. Drugs that normally suppress consciousness. His eyelids drooped. His body lay still. But the EEG remained unchanged. The surface of sleep without its depth. Pharmacological quiet without physiological rest. At this point, the boundary becomes clear. This is not failure of discipline or environment. This is not a disorder of mood. This is a neurodegenerative disease. And it does not begin where sleep is produced. It begins deeper. The disease targets the thalamus, a paired structure buried near the center of the brain. The thalamus is not a sleep center, it is a relay, a gatekeeper. It regulates the flow of sensory information to the cortex. It coordinates rhythms between brain regions. It is essential for the generation of sleep spindles and slow-wave oscillations. Without it, the cortex remains exposed to the world, even in darkness. In this condition, thalamic neurons begin to die, not abruptly, not diffusely, selectively. Specific nuclei degenerate. The damage is microscopic at first, but function is lost early. The circuits that synchronize sleep simply stop operating. This degeneration is driven by misfolded prion proteins, proteins that induce other proteins to adopt the same lethal shape. There is no immune response, no inflammation. The brain does not recognize the threat. The process is silent, self-propagating, irreversible. As the thalamus fails, the body enters a state of permanent partial arousal. The autonomic nervous system drifts upward. Heart rate accelerates. Blood pressure rises. Body temperature fluctuates. Hormonal rhythms lose alignment. Cortisol remains elevated. Melatonin secretion becomes irrelevant. The signals are sent. The receiver is gone. Weeks pass without sleep. The body should collapse. It does not. Instead, it degrades. Muscle mass declines despite adequate nutrition. Weight drops. The skin becomes dry. Eyes appear sunken. But the most significant changes are internal. Cognition begins to fragment. Not in the dramatic way of confusion or delirium. It is subtler. Attention narrows. Tasks require effort. Short-term memory becomes unreliable. Words are harder to retrieve. These changes fluctuate. Some mornings feel clearer than others. This variability creates false confidence. The brain attempts compensation. Cortical networks increase baseline activity. Other thalamic nuclei attempt to assume lost functions. The reticular activating system remains engaged continuously. This hyperarousal delays collapse, but accelerates damage. Neurons are metabolically stressed. Glucose utilization becomes inefficient. Oxidative injury accumulates. Dreams begin to intrude into wakefulness. Not vivid hallucinations, brief distortions, peripheral movement, misinterpretation of shadows. The boundary between internal imagery and external perception thins. The patient remains aware enough to be disturbed by this. Insight persists. Speech changes. It becomes slower, less precise. Sentences trail off. The voice loses modulation. Emotional expression flattens. Not because emotion is absent, but because the neural systems coordinating expression are destabilizing. The body continues to function. Organs remain intact. Blood tests are often unremarkable. Imaging may appear normal early on. This disconnect between severity and findings delays recognition. The disease advances regardless. Eventually, micro-sleeps attempt to emerge. Seconds of intrusion. Brief lapses. The brain tries to force rest through collapse rather than coordination. These episodes are insufficient. They provide no restoration. They are followed by autonomic surges. Tachycardia, sweating, panic without fear. Motor control begins to erode. Gait becomes unsteady. Fine movements degrade. The cerebellum is not the primary target, but it relies on thalamic integration. The loss of relay disrupts timing. Movements lose smoothness. Tremor may appear. At this stage, the patient is no longer able to sustain ordinary life. Not because of fatigue alone, because the internal synchronization that underlies conscious agency is failing. Time perception distorts. Days blend together. Night loses meaning. The point of no return has already passed. There is no plateau, no stabilization. The prion propagation continues. Thalamic destruction spreads. Cortical involvement increases. The hippocampus becomes affected. Memory consolidation, already compromised by lack of sleep, now degrades structurally. Personality changes follow. Not dramatic shifts, subtractions. Humor fades. Initiative declines. The patient becomes passive, not depressed in the clinical sense. The motivational circuits no longer coordinate. Desire loses traction. Autonomic instability worsens. Blood pressure fluctuates unpredictably. Heart rhythm becomes irregular. Temperature regulation fails. These changes are dangerous, but they are secondary. The primary loss is central integration. Sleep is now absent in any meaningful sense. EEG recordings show continuous wake-like activity punctuated by brief chaotic patterns that do not correspond to known sleep stages. The brain has forgotten the sequence. It no longer remembers how to descend. At this point, sedation no longer even simulates rest. Anesthetics suppress responsiveness, but do not restore rhythm. When drugs wear off, the same state returns. The machinery is broken. The patient remains conscious for much of this, aware enough to observe his own decline. He recognizes faces, he understands language, but he cannot organize himself within time. The sense of self-continuity erodes. Each moment stands alone. Speech becomes sparse, sometimes absent. Not from aphasia, but from loss of initiation. The will to speak does not arrive. When prompted, responses are delayed. Flat, minimal. Eventually, consciousness fragments further. Attention cannot be sustained. The world becomes overwhelming. Sensory gating fails completely. Sounds, light, touch arrive unfiltered. The cortex is exposed without mediation. This produces agitation, then withdrawal. Identity dissolves before death, not metaphorically, biologically. The neural networks that maintain a coherent self-model depend on sleep for recalibration. Without it, and with structural destruction of central relays, the model collapses. What remains is wakefulness without agency, awareness without rest, a brain locked in an irreversible state of arousal until systemic failure follows. Fatal insomnia. Not the inability to sleep, the inability of the brain to generate the state of sleep at all. Once it begins, the outcome is fixed. The person is lost long before the body stops. This is pathology of fear, and this fear is real. Because sometimes the most devastating outcome is not death, but the irreversible loss of self when the brain forgets how to sleep.